Hello, everyone. Happy Friday. Welcome. It's my pleasure to introduce Robert Tennant, WEDI's Vice President of Federal Affairs.
Thank you, Michael, and let me add my welcome from a cold and snowy Washington, D.C. area. Maybe to warm things up, I'll have folks put in the chat where they're calling in from and what the weather is where they are. We do ask if you are on a beach with a laptop in Hawaii, you don't gloat. So let's go to the next slide. Many of you have been involved with WEDI. Some of you may not. This may be your first exposure to our organization. So I thought I'd take just a couple of minutes and tell you a little about who we are. We were formed way back in 1991 by then Secretary of Health and Human Services, Dr. Lewis Sullivan, who knew firsthand some of the challenges providers and payers faced in exchanging health data. So he actually called together some of the leaders in healthcare and had them draft reports identifying some opportunities to streamline data exchange and create administrative simplification. Those reports were combined and included in the language which we now know as the Health Insurance Portability and Accountability Act, or HIPAA. WEDI was named as an advisor to HHS in the law, and we have served in that capacity ever since. In fact, we have both the Centers for Medicare and Medicaid Services and the Office of National Coordinator for HIT, both on our board of directors. Next slide. So how do we do our work? Well, it's all done through collaboration and consensus building. So we obviously track regulations like the one we're going to be talking about today. We have work groups which I'll talk about. We have conferences, forums, and webinars. We draft consensus-based comment letters on rules, and we engage in a number of special initiatives, all designed to improve the nation's healthcare. If you go to the next slide. And a lot of our work is conducted through our work groups and task groups. And you can see here we have a number of those 18 in all, including things like privacy and security. We have all of the HIPAA transactions. We have the No Surprises Act, Task Group, Health Equity, and many others. And I would encourage you, if you're interested in getting involved in one of our work groups, reach out through our work group community homepage that is on the slide here today. And next slide. A very special thank you to our sponsor, Edifex. In fact, we have Michael Patwell on our board of directors from Edifex, and they have been a wonderful partner for WEDI over many years. So if you're interested in solutions for some of the technical challenges we'll be discussing today, absolutely check out Edifex on their website. This is going to be a very interactive session. It's a unique opportunity to interact directly with one of the authors of the regulation. We'll do that through our chat feature, so please feel free to make comments and ask questions. No guarantee we'll get to all the questions, but we'll try to answer as many as we can. And as always, if you've signed up for this event, you will receive both the slides and a recording following the event, and you can share those with your colleagues. So with that, it is absolutely my pleasure to introduce Alexandra Mugge, who is the Chief Health Informatics Officer and Director at the Centers for Medicare and Medicaid Services. Alex has been a wonderful partner with WEDI over many years, and we're absolutely delighted to have her share her expertise with you today. So with that, I will turn it over to Alex.
Thanks, Rob. And I am going, I don't know if you guys are going to share the slides or if I should, but if I am, can you stop sharing for a second? All right. Now, hopefully you all can see the slides for the interoperability and prior authorization final rule.
Yeah, looks great.
Thanks so much for confirming that. So thank you very much for having me here today. I really appreciate the opportunity to share this rule with you. I understand that it has only been out for about 2 days, so I am going to give a general overview of the rule and the final policies, but there's always an opportunity to come back and answer more questions, or for you all to follow up with your questions after. So don't worry if you haven't read it yet. At the end of the deck, there is a slide with resources for more information, and there's also an email address for follow-up questions. The slides are currently posted on our website, but as Rob just said, they'll also be distributed to you along with the recording. So lots of opportunity to see this presentation and check out the details in the slides. So on January 17th, on Wednesday, CMS released the Interoperability and Prior Authorization Final Rule. This rule demonstrates CMS's continued commitment to increasing efficiencies by ensuring that health information is readily available at the right place at the right time so that patients and providers can make better care decisions. We are committed to improving access to information as well as interoperability, and to improving processes like prior authorization so that providers can put more time into taking care of their patients. When we were formulating the policy for the proposed rule, we heard extensive feedback about the challenges of prior authorization. And actually on Wednesday, when this rule rolled out, I was visiting Inova Hospital in Fairfax, Virginia, where we heard directly from providers and some patients about their challenges with prior authorization and the way that it exists today. And so much of what I heard was extremely challenging to listen to, because I kept thinking of the ways that the policies in this rule can help to prevent those challenges, can streamline these processes, make them quicker, get feedback back to patients and to providers so that they don't have to have long wait times. So hopefully years from now, when all these policies are implemented, those stories will become fewer and fewer, and patients will be getting more timely access to this important care. But it's those stories and the public comments that help to inform the final policies that I'm going to go over today. Public comments, including from the Weedy community. So thank you very much for providing those and for your ongoing feedback in this process. We did make a few changes based on that public feedback from the proposed rule. And one of them I do want to highlight right here on the first slide. So in the proposed rule, we had proposed that everything would be implemented by January 1st, 2026. However, we did hear from the community that additional time is needed to implement some of the more technical aspects of the API implementations in the rule. And so policies related to API implementation have been moved to 2027, whereas some of the non-API policies are still in 2026. And I'll do my best to make sure that that's clear as we go through each of the slides here and those policies. Then finally, before I jump into the rule, I do want to also mention there was significant public feedback that requested that we include drugs in our drug prior authorization in our final policies. We did not propose to include drugs in these policies. This rule is strictly limited to prior authorization of medical items and services. Again, not drugs. Prescription drugs already have prior authorization requirements, but there is a category of drugs covered under the medical benefit that do not fall under those requirements and are not included in this rule. We did hear, like I said, extensive public feedback about that, and it is something we're exploring for the future. So I just wanted to head that off right from the start, so I don't, say it too many times throughout the presentation. But do know that that is something that we've heard you, and we are going to look into that or are actively looking into that for future policymaking. So the final rule does include several policies for both payers and for providers. There's a list of provisions here on the screen, which we've included for reference, but I'm going to walk through each of them in the coming slides, so I won't read them off now. But I do want to be clear about who is impacted by the rule. For impacted payers, that would include Medicare Advantage organizations, state Medicaid and CHIP agencies, Medicaid and CHIP managed care organizations, qualified health plans, and the federally facilitated exchanges, or as we commonly refer to them as marketplace plans. And so those are the payers that are impacted. When we talk about impacted providers, we're talking about eligible clinicians, start with what's on the slide here, eligible hospitals and critical access hospitals that are participating in the Medicare Promoting Interoperability Program, and MIPS eligible clinicians participating in the Promoting Interoperability Performance category. So that's quite a few programs that CMS oversees and regulates, and will have a significant impact on millions of lives when these policies are put into place. So I'm going to start with the policies for payers, and I'm going to start with what we call the access APIs. We refer to these next three APIs as access APIs because they are a way to improve access to information. This is one directional information flow where the information is coming from a payer to its intended recipient, in this case, either a patient, a provider, or to another payer. So the first access API we're going to talk about is the patient access API. The patient access API was actually previously finalized in the CMS Interoperability and Patient Access Final Rule and was implemented in 2021. So this API already exists and should be available to any patients that are enrolled in the plans that I previously mentioned. This API currently includes information on claims and encounter data, as well as data classes and data elements in the content standard that was adopted by our colleagues at the Office of the National Coordinator, ONC. This is the data classes in the content standard, the US Core Data for Interoperability, or USCDI. So again, this data should already be available to millions of patients. In this rule, we have finalized our policy to expand that API data to include information about prior authorization. This is to improve transparency for patients so they can understand what is the status of my prior authorization and what prior authorizations have I had to date, what's currently active, and what's expired. This new data policy would be implemented by January 1, 2027. So this is because it is an API policy, we did extend the deadline by 1 year to 2027 to give everyone time to implement and test and make sure that this is fully ready and standardized and programmed in a way that patients can access and understand their information. The second policy we have related to the patient access API is to report API use metrics. So starting in 2026, we will be requiring payers to report annually on the patient access use metrics to CMS. This is to give CMS more information about the use of this API and to maybe help us to better identify where we need to emphasize patient access to this information and where we can support payers in helping patients get access to that information. The second access API is the provider access API. So starting in 2027, impacted payers must implement and maintain a provider access API that will share patient data with in-network providers with whom the patient has a treatment relationship. And there is discussion of attribution here on the slide, which we've included for reference. There's also a discussion of attribution in the rule itself, which I encourage everyone to take a look at that particular section if you have questions of how that attribution would work. This API includes, just like the patient access API, includes claims and encounter data, but it will exclude enrollee cost information. So there will not be patient financial information included, but it will include information about what the claim was, when it took place, that sort of thing. It will also include the data classes and data elements in the USCDI, and it will include that prior authorization information. So in this way, patients and providers will both have access to this information. They will be looking at the same thing and can engage in a dialogue based on the same set of information. So very helpful for promoting those conversations between patients and their providers. I do want to highlight that this policy is an opt-out policy. So providers can work directly with health plans on gaining access to this information without the patient having to be involved. However, if a patient does not want their data shared, they do have the opportunity to opt out of this particular policy for data sharing. There may be other instances where payers and providers have to exchange information for treatment, payment, or operations under HIPAA. But if the patient wants to opt out of this particular type of data sharing, they do have the ability to do so. The third access API is the payer-to-payer API. So starting in 2027, impacted payers must implement and maintain a payer-to-payer API that would include the same data that's available in the provider access API. So the claims and encounter data, excluding the financial cost information, all the data classes and data elements in the US CDI, and information about prior authorization. This API is intended to allow patients to bring their data with them when they change health plans. So when you're moving from one health plan to another, you can bring in, we have time limited this to 5 years, 5 years worth of data from your previous payer that will allow your new payer to promote care continuity, care coordination, to give you a little more insight to your payer about what possible conditions you might be working with, so they can help get you the right treatment more quickly. This also allows patients to bring their data with them so the patient themselves don't lose that information, so that when they go to the new payer, they don't automatically lose all of their history, but they still have access to that 5 years worth of information for their own personal reference. This policy is an opt-in, so payers must notify patients about their ability to opt into this, and the payer is also responsible for working with the patient to identify previous and concurrent payers to support this policy. So patients would need to opt in for this data sharing to take place. And we anticipate that many payers will be interested in working with their patients to do so. I did mention concurrent payers just now. I want to be clear that for patients that have concurrent payers, this would be an ongoing data exchange, and we expect that data exchange to happen quarterly. Whereas if you're simply changing from one payer to another, it would be a one-time data exchange, over and done, because there would be no need for further coordination with the payers. So in terms of educational resources, what's not listed on this slide, but I do want to mention, is that in the CMS Interoperability and Patient Access Final Rule, we did previously finalize a requirement to give patient educational resources. So that was already in place. These additional educational resources that will be implemented in 2027 for the Provider Access API, impacted payers would provide plain language resources for both patients and providers about the use of this API. And for the payer-to-payer API, impacted payers must provide plain language materials to patients about the benefits of the API and their ability to opt in. So getting back to that opt-in topic, information about how patients can do that and some of the benefits that they would gain from doing so. So moving more directly to the topic of prior authorization, until this point, we've talked about the access APIs, and I mentioned that that's about data flowing from the payer to a patient, provider, or another payer. So again, that's a one-way exchange. This next API includes bidirectional data exchange, so data going two ways to initiate and facilitate an administrative process, in this case, the administrative process of prior authorization. So this does require that both systems, both on the sending and receiving ends, have implemented the API, and that they have done so in a way that is standardized so they can talk to one another. All of the APIs covered in this rule are FHIR-based APIs using the FHIR standard. So certainly standardized, and we'll talk a little bit more about those standards in a moment. But for this particular API, impacted payers will be required to build and maintain a prior authorization API that can do, we refer to it as like 3 steps. First, identify whether prior authorization is even required. So yes or no, payer, do I need to do prior authorization? Then determine if the prior authorization is required, what payer-specific documentation requirements are included. So instead of a provider having to go out and find that information on a payer's website, this should automate the process by making that payer-specific documentation available directly in the EHR workflow for the given provider. And then finally, the third step in this process is actually submitting the prior authorization request and receiving a response. So all of this process should be automated and much more seamless to providers, happening directly through their EHR workflows and happening ideally much more quickly than the labor-intensive manual process that exists today. Since I did mention we're going to talk about the standards for these APIs later, but I do want to highlight, as many of you may be familiar, prior authorization is a HIPAA administrative transaction. So that means that under HIPAA, the Secretary for the Department of Health and Human Services is required to identify standards for the transactions that are listed as HIPAA administrative transactions, which prior authorization is one of those. The adopted standard for prior authorization is currently the X12-278. And at the time, but as I mentioned, of course, this API is a FHIR-based API. So the way that we proposed this was that there would be FHIR on both ends of the equation with a translation to the X12-278 in the middle to be HIPAA compliant. However, at the time that this rule was released, HHS, our department level entity, also announced that they would be exercising enforcement discretion of the X12-278. That means that we will not enforce the use of the 278 in the prior authorization transaction. And this applies to everyone, not just those that are covered by this interoperability rule, not just the impacted payers and providers of this rule. This applies to all covered entities, that now you have the ability to do an all FHIR transaction from end to end without that 278 translation. The National Standards Group, which is part of CMS, has the delegated authority from HHS to make this decision. And they did so based on many factors. This is a very unique situation in which we've decided to do this. And so working together with them, we have made this possible for now. And the National Standards Group will continue to look at future rulemaking and the use of these standards for future development. So moving past the APIs that we've covered so far, I truly believe are going to be transformative in healthcare. After hearing the patient stories that I heard just on Wednesday and even before that, and knowing that this API can truly automate the process and make that process better, I believe that this, what we've talked about so far in itself will change healthcare. But we also know that automation and technological solutions are not always enough to deal with the complex challenges of healthcare, and specifically in this case with prior authorization. So to truly scratch the surface of prior authorization reform, we need to look at process changes as well. And that's why we included several non-technical requirements for payers, including what is listed on the slide, and I'm going to walk through here. I do want to highlight the implementation date for these policies is, again, because it's not API related, January 1st, 2026. So getting some of these things in place even before those APIs are in place. So the first requirement on this slide is the reduced decision timeframes. So we are requiring that the impacted payers respond to prior authorization requests within 72 hours for expedited requests and 7 days for standard requests. This policy does apply to all impacted payers except for the qualified health plans or the marketplace plans. And the marketplace plans are looking at other ways to address timeframes, but they're not included in this particular policy. I do want to mention as well, before I move to the next policy, we received extensive comments and requests that we reduce these timeframes even further. And we will consider that for future rulemaking. However, at this point in time and where we are with the technology build and other factors, we felt that the decision timeframes as proposed with the 72 hours and 7 days was a good starting point for payers as well as for providers and patients. And so keep a lookout for maybe future regulation, but for the foreseeable future right now, we are keeping it limited to what was proposed at 7 days and 72 hours. The next policy does apply to all impacted payers, including the marketplace plans, and that is to provide a specific reason for denial. This would apply regardless of how a prior authorization is submitted and responded to. So whether it's through the API or any other mechanism, impacted payers must respond to a prior authorization denial with a specific reason. Can't just say it's denied, you got to tell us why. And that is intended to support providers' ability to either appeal a decision or resubmit their prior authorization or determine a different course of treatment for their patient. Perhaps the reason for denial is something that they can't overcome, but then they'll have that information so that they can determine what the new course of treatment should be, and they'll be able to do that in a timely manner. So we feel that this is a critically important piece that will help to streamline the process even beyond the technology and the timeframes. This is something that's critically important for decision making in healthcare. And for that reason, The denial reason should be clear, specific, and actionable. And we were clear about that because the actionable piece is what's really going to help providers and their patients make decisions about patient care. Then finally, on this slide, we are requiring payers to report certain metrics about prior authorization performance on their individual websites. So this information would be on the payer-specific website. I will highlight that CMS in our Medicare fee-for-service business has already made some metrics about our prior authorization performance available publicly. You can download that. It's a PDF that is posted on the cms.gov website. We expect the information that payers will post will be clear and understandable, accessible and transparent, and will provide information such as how many prior authorization requests are approved, how many are denied, overturned on appeal, etc. So really information that will be transparent and informative to patients, providers, other payers, everyone. Again, it's publicly available. Anyone can use it. So moving on. So everything we've talked about from up till now has been about the impacted payers. And now I want to shift the conversation to policies for those impacted providers. So again, that's going to be eligible clinicians, hospitals, and critical access hospitals that are participating in the promoting interoperability programs. This policy that we are finalizing will introduce a new measure, the electronic prior authorization measure, into the respective clinician and hospital programs. This measure will require the clinician, well, I'll just call them all providers, will require providers to report to CMS whether or not they are using the prior authorization API. So in order to achieve compliance with program requirements, the providers would need to report a yes or claim an applicable exclusion. Like, for example, some providers don't do prior authorization, so they wouldn't be able to report that yes. But they would either report the yes or claim the exclusion in order to meet program requirements. If they report a no on the measure, which means that they are able to do the prior authorization, but they are not using the API, then they would not meet program requirements and would receive a 0 score in their respective programs. So just like the payer programs, we did extend the implementation timeframe from 2026 to reporting and performance periods in 2027. So giving also reporters and the providers that need to report and their EHR developers time to implement this part of the API and reporting requirements. But we do expect that by 2027, both payers and providers will be able to utilize this API, and providers will be able to report on the measure as listed here. This is a really important piece, I feel, of this overall rule, in that it brings both the payers and the providers to the table to use this API. An API built one-sided in this scenario will not help to improve prior authorization processes, but by bringing providers and payers both to the table to use this API, we are really coming full circle and making sure that those requests and responses can be automated and can be integrated into the provider's workflow. I mentioned that we were going to talk a little bit more about standards, so here we are. In this rule, we did modify some of the language that we had previously finalized in the previous interoperability rule to help clarify and provide a little bit further distinction on which standards would apply to which APIs. We also included discussion of how developers can use updated version of standards, even if those are not the ones that we have adopted for use in this rule. So actually, I think it's a little easier if we go right into these next slides to give a little bit more context to which standards are required. This first slide outlines the required standards and to which API each of them applies. These standards have been adopted by ONC, and we are now requiring them for each of the APIs, and it lists out patient access, provider access, payer-to-payer, and prior authorization APIs, which I covered today. We also included some clarification on the provider directory API, which is one that was finalized in previous rulemaking. So I won't walk through each one of these, but this slide is available for reference, and there's additional information on our website on how each of these would apply, as well as links to more information about the standards themselves. So this next slide is about the recommended implementation guides or recommended standards for the APIs. So unlike the previous slide, These are technically optional, but I want to take a moment to talk about what that means. So while we're only recommending and not requiring the use of these implementation guides, I do want to highlight that we are considering requiring them for future rulemaking. So they should be strongly considered in API implementation. These guides are what's going to get us to interoperability. They are use case specific. They help detail how to implement a FHIR-based API for the specific use case. They also support the particular requirements that we include for each of the APIs. And so this level of specificity and implementation will again be like what gets us to the standardized, the interoperable data exchange that we are working towards with the policies in this rule. So we know that some of the API, these implementation guides are still being refined. Some of them will be tweaked as implementation is broader and used more across the industry. There may be additional tweaks that have to happen to these implementation guides. And that's why we wanted to provide the maximal flexibility by not requiring them, at least at this point in time. So that may not always be the case. But at this point in time, because some of these are still undergoing modification, we didn't want to lock anyone into a particular version. And so we are strongly recommending them. Probably said that enough times and can continue forward, but I do want to highlight that because again, this is what gets us to interoperability. This is what's going to help with that consistent implementation that allows electronic prior authorization and really brings the full benefits of these APIs to these final policies. I did promise you there was a resources slide at the end here. So there are links to more information about the rules, more information about the standards, both the required and optional implementation guides here. And on the last slide, we do have the email address that you can reach out to for more information or for more specific questions that we might not be able to get to on today's call. But before we go to the Q&A, I do want to say a huge thank you for allowing me to be here today and give you this overview. I also want to thank those of you who submitted public comments on the rule or who have worked with us over the years to share your stories. They had a significant impact on what is finalized in these policies. And we hope to continue hearing from you as we move forward, as I mentioned, with drug prior authorization and other policies. What really helps us to create these policies is by hearing from all of you. So thank you again, and I guess we'll open it up for Q&A.
Alex, excellent overview. Really appreciate that. And not surprisingly, we've got a lot of excellent questions submitted by the WEDI community. So I'm going to move down through them. I do warn we'll probably be bouncing from different areas of the rule, but we'll start with one from Janice asking if you can speak to whether non-US CDI U.S. core information is being used to make PA decisions. Is it still required to be included in the Access API?
Yes, so any information about the prior authorization is required to be included. The requirements vary a little bit. So in the case of payer to payer, there is some more information that is required to be exchanged. Strongly recommend that you take a look at what those requirements are. But if they, to more specifically answer the question, if there is data beyond the US CDI that supports the prior authorization and that the payer maintains in their systems, we would expect that would be exchanged as part of that requirement.
Excellent. One from Donna, is this billable provider sharing too, or just attributed provider? She argues providers would benefit from claims as FHIR as well.
Could you read the question one more time?
So is this billable provider sharing as well, or just the attributed provider?
I think I'm having trouble with the distinction of the billable provider versus attributed provider. So the attribution process may work differently among different payers, but if the provider is in network, and has a relationship with the patient that can be established through the attribution requirements of the payer, then those providers would have access to the information. And again, just because they mentioned claims, I want to highlight that while claims and encounter information such as the nature of the claim and the date that it took place will be included for the provider access API, we are excluding any sort of enrollee cost sharing or financial data that would otherwise be made available to a patient. If I didn't answer the question completely, they can certainly either submit it or follow up in the chat. Apologies.
And I believe I read in the rule that denied claims would be included as well, correct?
Thinking back, denied claims. I need to go back and check that because between the claims and prior authorizations, I want to make sure I don't confuse things, but we'll circle back on that.
Okay, good. And Christopher asks, for payer to payer, is it one and done for non-concurrent? And the big issue for him is the claim run out. So if a claim was submitted after the date of the request from the SAC and payer, does the first payer need to go back and feed that information?
That is a really, really good question and one that we had a lot of discussion about. So when we say one and done for payer to payer, that means that when a patient is moving from one payer to another, there would be a one-time data exchange to help move that data with the patient over to the new payer. I believe we did seek comment on what that run out period would be or what that could look like. And I will follow back up. I believe it is one and done. But there is discussion about a follow-on period after that for exactly that reason. For a patient that sees a doctor in December, and let's say they change plans in January, that claim may come through at a later date. And so I will again follow back. You guys are really good with your questions, given this has only been out for 2 days.
Oh, there's plenty more. A general one we've been hearing about is commercial plans are not generally included under the rule. Are there any plans down the road to issue rulemaking for that particular segment?
So we did try to touch on the majority of plans for which we have authority to do so. Many of the payers that are regulated in this rule may have, for example, their Medicare Advantage line of business that is covered by the rule, but then they have other lines of business that are not. We anticipate that most payers, and we encourage payers to implement this across all of their lines of business. We think there is lots of value in each of the APIs and the prior authorization processes that we discussed. And so it would probably be much cleaner for payers to implement across, but it is not required for the lines of business that aren't covered in the rule as impacted payers. That said, we are always exploring ways to make sure that we can increase efficiencies in healthcare, and certainly this prior authorization piece is a big part of that. So if there are opportunities to do so, we will continue to explore that.
Excellent. We've got there's a lot of interest in the enforcement discretion regarding use of the 278. The question is, does this enforcement discretion apply, for example, to these commercial health plans as well as the plans covered under the rule?
Yes, the enforcement discretion is for all HIPAA covered entities. So whether or not part of this rule, this enforcement discretion is in place. I want to be clear, and there will be more information posted about the enforcement discretion. So more to come, but just to maybe head off additional questions on that particular point. This enforcement discretion is only for those who are implementing the FHIR-based API. So if you it's not wild west or anything, like you can't go and use whatever standard you want, but if you are implementing a prior authorization end-to-end FHIR API, then you do not have to use the 278. You may also choose to do the approach of having FHIR on both ends with the 278 in the middle. We just call that the hybrid transaction. That's an option. And then finally, there may be some payers who choose to also offer an all 278 transaction, and that is okay too. But if you're an impacted payer of the rule, you do have to have the FHIR-based API at least.
Excellent. Gary has one for a patient that starts with payer A, then moves to payer B, then finally to C, suppose B got information, does payer B need to send the data received from payer A to the current payer C? I don't know. It's a bit convoluted.
I think I followed. So, so in either case, whether payer C is going to payer B or payer A, the requirement is that you provide from the date of request back 5 years. So if payer B has 3 years worth of data and payer A, has 1 year that overlaps and some other data, the goal is to get back to that 5 years. So whatever each of the payers maintains in their system, whatever they have access to, that's what they would send to payer C.
Excellent. Michael asks, can you clarify the matrix reporting requirements, first date to report, and covering what time period?
So we have 2 metrics, and so I apologize. There's going to be probably more information than you were looking for patient access API metrics. The state or whoever the impacted payer is would report on how many patients are using the API and how many people have accessed the patient access API, and that data would be submitted to CMS. For the prior authorization metrics, that data would be posted on the payer's website, and we do list out what the individual questions are. So again, it's similar to I'm really paraphrasing here, but it's number of prior authorizations that were approved, the number denied, those that were overturned on appeal, and there's at least 1 or 2 more, which are all outlined in the rule. This information would be put together in a, of course, de-identified and aggregated way, made available on the payer's individual website. And while we were not super prescriptive about what that should look like and how it should be displayed, we do say that it has to be publicly accessible, very transparent. And if you're looking for examples of ways to do that, you can see what CMS has done for the Medicare fee-for-service program.
Excellent. We've gotten a number of questions on software certification. I guess my question would be, do you have any insight on whether or not ONC will be issuing rules to support this particular rule in terms of adding this to their certification requirements?
So it's a good question. Certainly, and one that we too got through public comments, and I'm sure we'll hear about again. I can't comment on future rulemaking especially not of a different agency, but I will say that it's a great question, and we would certainly, we certainly plan to continue working very closely with ONC to make sure that all of these policies can be implemented.
Excellent. One more question on the 278. Kathleen asks, what if a particular state requires the use of the 278?
So state requirements would be a different, I think we have to think about how that would work. If the state requires it, I think you would still have to use it. Though the states may decide to revisit that decision based on the enforcement discretion, that's something that you would need to follow up with your state.
Okay, good. Chantel asks, I think a good question here. There was obviously some pilots, some exceptions done in this area. Is there any plans for CMS to release the results of those exception pilots?
Yes, so we did receive some preliminary results, which is also in part what contributed to the decision to do the enforcement discretion. Preliminary results are very good, very promising. The exception runs through sometime in the spring, and I think that there will be a final report, and I believe that information will be made public at that time. And then there will also be some follow-up in the overall process for the exception.
Excellent. Donna asks the question, has the volume of unstructured documentation going back to 2016 for PA and for concurrent review been considered in the cost impact? Obviously, we're looking back then at paper faxes, for example.
Right. So that is certainly there is ongoing storage and maintenance factored into the cost of the year-over-year cost for APIs. And there is discussion about the exchange of those documents. And I do want to highlight that, in part, the reason for limiting the payer-to-payer data exchange, limiting that back to 5 years, was in response to comments about some of the challenges of exchanging this amount of data and having that data grow over time. So we did certainly factor that into the final policies as well.
Excellent. I know the issue of a definition of standard versus expedited PA was included in the rule, but the question from Tammy is, who defines if the prior auth is a standard one or expedited?
Yeah, that is a really interesting question, actually. So the provider can indicate whether it is an expedited or a standard request. I believe that it still needs to be stated explicitly if it is one or the other. And I don't believe that it is built into the standard. So the provider would need to reach out and indicate whether it is a standard or expedited. If I am wrong on that, I promise to send a follow-up to clarify. But certainly that is something that needs to be indicated as part of the request itself.
Question from Catherine, is the FHIR version requirement a minimum, or is it the only version that can be used?
Oh, so that allows me to expand a little bit on our standards advancement process. So we are actually sort of following on to a process that ONC had finalized, which is a standards versioning advancement process, or SVAP. We love acronyms in government. So the SVAP process would say that this is the standard is the floor, the base requirement, and that you can use updated versions of the standard. However, until the version is actually replaced through rulemaking with the updated version, you may still need to maintain the older version of the standard for interoperability purposes and to ensure that everyone can access the data. And I will just take a moment that, in this opportunity to say, this is one reason that I believe, one, we have really great job security, but also that this rulemaking will probably, go on because forever, because we know that industry is going to continue to innovate and build on these standards, and we want that to happen. We don't want to stifle innovation with these policies by locking anyone into an early version of the standard, and in part that is why we did not require the use of the implementation guides. But going forward, we'll have to continue to evaluate these and determine when is the right time to update that floor or base version to a newer version. And that's something that we will require input from the standards community and, continue conversations that we have with all of you to make sure that we identify the right time to do that. And again, that we don't keep anyone stuck in a particular version or stifle innovation.
No, I appreciate that. I think there's a lot of interest in the IG issue being recommended rather than required. So I think that'll be a huge issue for the industry.
And before we go anywhere, I want to make sure that I clarify. I did receive a text telling me that there is a marker in the IG for the prior authorization IG to indicate if something is expedited. So that is something that is going to continue to be expanded upon in future versions. So once again, another good reason that we're not locking anyone into a particular version of those standards. Sorry, Rob, I didn't need to jump back.
No, that's great. A great point. John asks, the original PA APIs were rarely used by members. Does CMS expect this usage to go up with so many other ways for members to get information? I guess asking what your thoughts are in terms of whether use of the API will significantly increase.
Is that in reference to the prior authorization?
Yes.
Exchange? Okay. So the previous, as we mentioned, with prior authorization being a HIPAA transaction standard, the previous standard for electronic exchange was the X12278. So there wasn't an API requirement. There was a standard requirement that if you're going to do electronic exchange, you have to use the X12278. In this rule, we are now requiring that you build the API, and again, a FHIR-based API. So we do anticipate that use of this will increase for a few reasons. One, because it's required both for the payers and the providers that are impacted in this rule. And two, based on the preliminary findings that we have heard about those who are using an all-FHIR API for prior authorization, it increases productivity significantly, and it streamlines the process for providers, saves them a ton of time, makes them much more efficient. And while I'm not going to pretend that's going to happen overnight, like I know there's a learning curve, I know we have to build this out, and that providers have to get used to the new workflows and so forth. But over time, I think that the efficiencies gained and what people see is making this process much more manageable. They will want to adopt the API even beyond what is required in this rule.
Excellent. Back on the IGs, Rene asks, do you, and this may be more of a question for the HL7 folks, but do you anticipate the modifications to the recommended API IGs will be completed in advance of the 1/1/27 implementation date?
So that is certainly a question for HL7, but I think that of the work that is in the works now, and what we're expecting to see in the coming months, I think that certainly there will be some enhancement to support the implementation of this rule on some of the IGs. Now, each of the IGs is in a different state, so I want to be clear. Some of them are far more developed than others. Some of them we probably should be requiring today, but we're really trying to be consistent in our approach. So anyway, that is all to say that I think that you'll be in very good shape well in advance of the implementation requirement and the compliance date, and that and also encourage folks to engage in that process, because it is open to the public. So you're more than welcome to engage if there are enhancements that you want to see for any of the IGs.
Excellent. We've got a question from Jay, former WEDI board chair. Draft version of the rule required payers to share data in original format with requesting payer. It appears in the final version this requirement has been dropped. Is that correct?
In the original format. So are they talking about the unstructured data? May need to follow up on that.
Okay, good. From Donna, what about states that have PA exceptions for eligible providers, for example, like gold carding? Does this rule cover providers regardless of the PA exception if a PA is done as a recommended check for medical necessity review?
So let me just I may make a few assumptions here in answering the question. So I think that what they're saying is that for some providers who have a gold carding exception, so they don't have to do prior authorization, would they still need to report the measure, the electronic prior authorization measure, as part of the promoting interoperability programs? And the answer would be, if you are not required to do prior authorization, or you don't do prior authorization, then there is an exception in to the measure in the rule. So you'd be able to claim that exception, and the reporting requirement would then essentially not apply to you. However, if you do prior authorization, it's only required that you do this once. So we expect providers will both want to and be encouraged to use electronic prior authorization much more often. But even if you do it once, you would need to then use the API and report a yes on the measure.
A very good question from Christopher. It's likely that providers will need to connect to a multitude of different payer endpoints. How will a provider find those endpoints to be able to connect?
So we do reference this a little bit in the rule, and I'm not pretending that there are perfect solutions out there right now. But what I will say is, one, I know there's a lot of industry development around this and considering this topic, and also the types of apps to be used for prior authorization within your EHR. But in terms of the endpoints themselves, so CMS did release an RFI last October, not last October, but last October, about a national directory for it was national directory for providers and services. And in that, we talked about digital endpoints for both the provider side as well as payers and other entities in healthcare. And that is something that we are pursuing and that we, hope to be able to support industry with. And I guess I will highlight that there are some digital endpoints for the Medicaid states that is currently available on the CMS website, but I think we're going to try to do one better than that for the future, and we'll be exploring how we can support with those digital endpoints through a CMS supported system.
From Diana, we've got, I see standards required and recommended for the API, but was there a standard recommended, for example, 50-10, 60-20, 80-20 for the prior auth portion of the rule?
So for the prior auth portion of the rule, we are recommending the DaVinci CRD, DTR, and PAS IGs, 3 separate IGs. And for prior authorization itself, that is the PAS, the Prior Authorization Support Implementation Guide. And so it is a FHIR transaction, so it would not be using what is recommended in the rule and required in the rule is the FHIR recommended part, and the prior authorization support implementation guide is recommended. And so it does not include those X12 standards versions.
And I know that it was not required, but the question from Banu is, what is the attachments standard recommended for prior auth in the rule?
So that's a good question. We actually don't have necessarily a requirement or a recommendation on the attachments. When we did propose the rule, again, because the X12-278 was part of the equation, there was reference to also the X12-275, which was optional. But as many of you know, CMS and HHS have not formally declared an attachments standard. So there's, I think, still a lot to unpack with attachments. There is an HL7 attachments support version as well. And so that will be until further information on requirements for attachments, that will be up to the implementer to decide which they want to use.
Excellent. We'll end with one question on Medicare. I understand that they're going to be offering some testing processes to providers. Can you give us a little more intel on that, when that process will start and what it will look like?
So the when you say testing, I'm going to assume we're talking again about prior authorization.
Correct.
I know there's also the provider access API, which for Medicare fee-for-service is the data at the point of care API, and there is an ongoing pilot for that as well, so which you can read more about if you look up data at the point of care API on the CMS website. But for prior authorization, the API is available now for testing, and it can support prior authorization requests electronically. So if I actually did reach out to make sure I had the right email address for this. If you're interested in testing and piloting the FHIR prior authorization server at Medicare Fee-for-Service, you can send an email to pcg-FHIR, FHIR, at medals.com. I'm going to put that in the chat.
Excellent. And with that, I wanted to thank you so much, Alex, not just for your presentation, but also phenomenal answers to some really tough questions. With that, Michael, if you can go to the next slide, I just wanted to highlight a couple of things before we break. WEDI obviously is going to be heavily invested in trying to assist the industry move forward with these new regulations. Next slide, please. One thing we are very committed to is education series. We plan to do a deep dive in each of the areas that Alex has covered. including the payer-to-payer API. It's scheduled for February 8th. We'll also have a session devoted to the patient access and provider access API, and then two specific on the prior authorization components of the rule. We'll focus on payers, providers, and patients, and then we'll look at EMR companies, early adopters, and pioneers. We'll have one focused specifically on small providers in mid-March, and then later that month, we'll focus on the small payer environment. Finally, we'll have a TEFCA update probably in early April. We'll know more about how things are going with TEFCA by then. All of these will be free to WEDI members, and if you're not a member, there'll be a small charge to attend. If you go to the next slide. The one thing I think we can all agree on is we've been down this road before. We went through the implementation of 4010, of 5010, of the national identifiers, and ICD-10. And so certainly there are some lessons learned there. We need education. We need industry buy-in. We need to be able to ask questions and get answers. We need to test. We need to survey. And we need to learn from early adopters. So that's some of the things that WEDI is going to focus on over the next months and years. Next slide, please, Michael. Just to give you a sense of what we're planning on doing, obviously education, helping to identify interpretations of issues and the standards and the rules, serve as an industry resource to resolve these issues, identify consensus milestones, develop a consistent survey approach so we'll understand industry readiness, certainly promote industry best practices, and perhaps most importantly, serve as an industry conduit to both the standards development organizations and CMS. Next slide. And again, if you're not a WEDI member, certainly reach out to my colleague, Bill Alder. If you're a member and want to be involved in our work groups, reach out to Samantha Holvey. So with that, again, Alex, I wanted to thank you. Phenomenal job. I know it's a huge undertaking to get this type of rule out, but it is, in my mind, a landmark, a rule, a game changer in healthcare. And so we're all looking forward to improving healthcare and implementing these very challenging rules. So with that, I will close the event. Thank you all, and stay safe in this bad weather. Take good care. Oh, as Michael said, we'll be sending out the slides and recordings. And again, a big thank you to our sponsor, Edifex. Again, check them out if you have any interest in interoperability and prior authorization. They can provide solutions to many of your challenges. Take care now.